My name is Vinny Mellnick. I am an associate professor and chief of abdominal imaging at Washington University in St. Louis, the Mellnick Institute of Radiology. This is a frequently encountered scenario in my practice. I would say in general, MRI is preferred to CT when it comes to detecting and characterizing lesions of the liver and pancreas. This is because MRI has better contrast resolution and many types of pulse sequences that allows us more opportunities to observe things like contrast enhancement, T2 and T1 signal, and diffusion restriction, and just to name a few MRI sequences that can help with lesion evaluation. Some common examples of where I think MRI is best used include the evaluation of liver lesions in the cirrhotic patient, characterization and follow-up of pancreatic lesions like pancreatic cysts, and in detecting and characterizing metastatic disease, especially tumors like colorectal cancer that commonly metastasize to the liver. One particular area where I think MRI is quite helpful is to look at and detail biliary anatomy prior to resection of a tumor that involves the liver and or bile ducts. One classic example is cholangiocarcinoma, because it's obviously critical to define the extent of disease with respect to the bile ducts before a potential surgical resection. In addition to the tumor itself, it also can allow us to detect anatomic variants of the bile ducts, which obviously affect a surgeon's ability to resect a tumor involving the liver. Now, all this is not to say that CT does not have a role in the evaluation of liver or pancreas tumors. Many patients will have their lesion first detected on CT, often performed for other reasons. But when it comes to performing CT in the evaluation of a known pancreatic or liver tumor, there are several situations to think about. First of all, patients who cannot receive gadolinium-based contrast agents, such as in the setting of an end-stage renal disease, will often better be served by doing a contrast-enhanced CT. Patients with pacemakers or other devices may be unable to get an MRI or may be unable to get an MRI promptly because of the complexity of performing these exams in patients with pacemakers and other devices. And so in those situations, CT may be a better choice. I would also note that CT plays a valuable role in defining vascular anatomy. In patients undergoing local staging for pancreatic ductal adenocarcinoma or hilar liver lesions, the extent of tumor involvement along the adjacent arteries is absolutely crucial, especially in pancreas cancer. And that determines whether or not a mass is resectable or not only during the initial staging, but in follow-up after potential chemotherapy and radiation. CT is better than MRI in this setting because it has better spatial resolution, and because the arteries of the upper abdomen can sometimes be quite small, oftentimes CT performs better when detecting subtle tumor involvement along the arteries. I would also note that one size may not fit all, and that oftentimes we end up performing both exams in patients who have hilar tumors or pancreatic tumors to allow the complementary role of evaluating the biliary anatomy with MRI and the arterial anatomy with CT, because these can often be quite challenging surgeries, and the most information we can give our surgeons, the better we think.